Thank you. It's really exciting to be here today. Thank you for inviting me, and thank you all for coming this morning. I'm a Utah native, so it's always great to be back home. There's no place like home. I'm excited to talk today about some DAGs that we often use in our research. And my research often comes at the intersection of methods and reproductive and nutritional epidemiology. So what we'll be sharing today is how these two worlds kind of intersect and connect, or in DAG terminology, how they collide.
Oh, gosh. Wait, how do this? I know, because I've never tasted this very much. Thank you, Courtney.
There we go. It's a good mood lighting.
Yeah.
And feel free to stop me at any point and ask questions. But I was trying to describe this off. I was struck by this quote in the article by Shire and Platt that said, although previous published articles have discussed the role of the causal directed acyclic graph approach with respect to confounding, many clinical problems require complicated DAGs, and therefore investigators may continue to use traditional approaches because they do not have the tools necessary to properly use the DAG approach. So kind of the purpose of today is to talk about what a DAG is. A lot of the examples we'll be using are overly simplified. Like, what I'm dealing with is a little more complicated than that. But the tools that we will be presenting today give you the foundation to be able to apply it in your own research. And it took me a bunch of times in listening to these methods before I started to feel more comfortable with them. I took the class from Jamie Robbins and Miguel Hernan, who are kind of the fathers of epidemiology in the causal inference realm. And I sat there the whole time and I had no idea what was going on. And I tell you this because going from that point to now, there's something that I feel much more comfortable with and have been applying in my own research. I had someone ask me, well, how long is it going to take me if you sit through these things and you don't know what is going on? Well, I think the key is really to start drawing a DAG with your own research. You kind of have to dig in, and once you start trying to explain the causal relationships that are going on in the research that you're doing to answer important public health questions, then it all starts to become more clear. So you kind of have to start playing with it, and then it becomes much easier. So why would we ever want to use DAGs anyway? Well, they help us determine the appropriate adjustment set. As epidemiologists, public health researchers, we're often very concerned about what variables we should be adjusting for. And DAGs help give us a tool to help us know what we should adjust for. They also help identify time-dependent confounding and the need for marginal structural models. Because usually when we're adjusting for something, we just throw it in the regression model, adjust for it. But there are some cases where that approach is not sufficient. And we'll go over that situation. And another reason to use DAGs is because they are going to make our assumptions explicit. All models are wrong, but some models are useful. We're making assumptions all the time, and it's good to actually put them on paper, draw them out, and be explicit about what we're assuming. So basic outline of the presentation for today. We really want to provide some tools to help you know what a DAG is so that we can move behind the theory that will be presented to some implementation in your own work. And we'll highlight this through an example of the birth weight paradox, which is a source of controversy in reproductive epidemiology. And we'll set the stage with the paradox, and then we'll give an introduction to what DAGs are, what confounding and selection bias look like in the DAG world. And then we'll go back to the paradox and use DAGs to see if we can sort out the paradox and figure out what's going on. And then look at another example of when we might need marginal structural models. So what is the birth weight paradox? Has anyone heard of the birth weight paradox before? A couple of you? Well, we know that birth weight is a really strong predictor of infant mortality. If a baby's born small, has a much higher risk of dying than a baby who is born full term and of normal birth weight. And so a lot of studies have looked at what impacts birth weight, looked at effective smoking, multiple pregnancies, placenta previa, to see if we can intervene and improve infant mortality. And the interesting thing is that when investigators have been looking at these associations, when they adjust for birth weight, they found that the birth weight specific mortality curves cross. So we'll talk about what that means. So here we have the distribution of birth weights in the United States. The mean is about 3,500 grams. And when we look at it by smoking status, the infants that are born to mothers who smoke have slightly lower birth weight overall. And so you would expect that because they have lower birth weights, that they would also have a higher risk of infant mortality. But what we see is this is birth weight across the bottom and the risk of infant mortality across. And you see the infants that are born at low birth weight have a much higher risk of infant mortality is what we would expect, and then it goes down as the infants are larger. But what happens is that the curves cross at this point. So all the babies that are born at very low birth weights, so the ones that would be at the highest risk for infant mortality, if their mother was a smoker, then they have a lower risk of mortality. So it's looking like in the infants that are at most high risk, smoking is actually good for the baby, which doesn't make a lot of sense. And so this is what is called the birth weight paradox. And what's interesting is that investigators have seen this not only for smoking, but for many other risk factors. So here we have the odds ratios for smoking, plurality, infant sex, and race by category of birth weight. And I've highlighted here the low birth weight categories. The most high-risk infants have a higher risk of mortality. If their mother smoked, protective. Multiple pregnancies, protective. Black race, protective. So you might ask, well, maybe we're not adjusting for important factors that are associated with infant mortality. So when we adjust for them, we see the same phenomenon.
Sorry, you left your mic.
Oh no.
You can keep talking.
Okay. So when we adjust for all this walking around.
Yeah.
Okay, there. Okay. So when we adjust for the other factors, we're still seeing the same phenomenon. So what is going on? Is this a biological fact? Is it a statistical artifact? There have actually been a lot of competing theories to try and describe what has been going on. And some people have argued that, yeah, maybe smoking is actually beneficial for these low birth weight babies, and suggested interventions for smoking mothers if they're going to, you might want to induce that labor and have a low birth weight baby, they're going to have a low risk of infant mortality. But it's also a problem looking at absolute and relative risks. This is looking at the relative risks. Relative risks are smaller, but the absolute risk for those infants dying is much higher at the lower birth weights than at the higher birth weights. So we've been trying to figure out what could be going on to explain this paradox. So is this a place where DAGs could help us? Well, we know that our goal is to examine the effect of prenatal smoking exposure on infant mortality. And we're going to use DAGs to provide a conceptual framework for understanding the paradox and help us determine whether or not we should be adjusting for birth weight. So why would we adjust for birth weight in these analyses anyway? Hopefully we're all familiar with these common confounding evaluation strategies. I know that these are different strategies that I've used many, many times. Automated stepwise procedures, a change in estimate approach, and the standard confounder definition that we're taught in FE 101. And we'll walk through each of these different approaches. So one procedure is an automated stepwise selection procedure, and this one usually gets a pretty bad rap, so it's not as common. But what you end up doing, you take all the variables that you think you might want to be adjusting for, you throw them in the model, and it will try different combinations. It will put one in. If it's significant, it'll keep it. It'll try the next one. If it's not significant, it'll leave it out. And so it goes through all the different possibilities, and at the end you come up with a model with all the significant confounders. And so the implicit assumption in using this approach is that although you're not going to select all the confounders, you're going to get the ones that are the most important. Another approach is the change in estimate approach. I do this all the time. You put something in, you see if your effect estimate changed. Did it make a difference? If it didn't, maybe I won't adjust for it. Maybe I'll leave it in. It doesn't really matter one way or the other. So here what you're doing is you're comparing the adjusted and unadjusted estimates. If it changes your effect coefficient by, say, more than 10%, some people use different cutoffs, then you'll keep that variable. So what you're assuming here is that any variable that is going to change your estimate substantially is worth adjusting for, and so that's what you want to adjust for. And then we have the standard confounder definition criteria. Is this factor associated with the exposure? Is it associated with the outcome? And is it not on the causal pathway? We can check through each of these criterion and decide whether or not we should be adjusting for a variable. So does birth weight meet these different definitions? Well, using the automated procedure, yes. It would always be a significant confounder because it's so strongly associated with both birth weight and infant mortality. The change in estimate approach, yes. We'll see some of the data. It changes the effect by, I don't know, like 30%, which is a substantial change, and so we would end up keeping it based on that approach. And using the standard confounder definition, yes, probably it's associated with the exposure and the outcome. And we'll look at how it meets the last criteria. But so based on all of these common procedures, we would put birth weight in the model. But what is potentially wrong with each of these approaches? Well, they each could potentially lead to bias in our estimates. They could cause us to leave out important confounders or inappropriately adjust for variables that can induce bias. And this is where utilizing the DAG approach can really help identify these situations. So they're a model building method that uses our a priori subject matter knowledge to show what our causal framework is. And using this framework, we'll be able to evaluate the effective adjustment for perceived confounding using DAGs. So we'll walk through the birth weight paradox and talk about the potential for confounding there. And we'll also show how standard adjustment for variables affected by exposure may introduce bias. And we'll get into some of these details as we go along. Basically, there are some cases where, yes, we want to adjust for that variable, because if we don't, we're going to get a biased estimate. But there are other situations where when we adjust for that variable and put it in the model, it's actually doing us more harm than good. And we're going to argue that this is what is going on with birth weight and the birth weight paradox. So let's talk a little bit about DAGs. How many people here have seen a DAG before or know what a DAG is? Has some exposure? I like to think of DAGs as figures that define our working causal framework. And a DAG, the name DAG has a very specific meaning. The D is from the word directed, which all the arrows in DAGs are single-headed arrows that show direct causal effects. So any arrow pointing from one variable to the next implies that there is a causal association between those two variables. The graphs are acyclic. No cycles are allowed. So you can't have A cause B and then B cause A again. You can't show temporality that way. If you want to look at temporality in a DAG, then you have to specify the time. So you can say A at time 0 affects B, which then affects A at time 1. And this, you can think of BMI throughout life. Let's see. So your childhood BMI may affect your age at menarche, which then could also be associated with your adult BMI. So you can show some temporality on the DAGs in that way. And their graphs will show lots of examples of what these actually look like, but each node represents measured or unmeasured variables. And all common causes must be shown on a DAG or it is not considered causal. So let's look at what confounding looks like on the DAG. Here we have E representing any exposure, D representing the disease, and C is any other covariate or factor that we're interested in. And here C is associated both with the exposure and the outcome. And we really want to estimate this effect here. What is the effect of E on D? And we want to make sure that when we're estimating that effect, when we're estimating the strength of this arrow, that there's no other association that could be influencing this association. So how do we evaluate this effect of E on D? Well, the naive approach, we just regress E on D to find out what the association of the exposure is on the disease. But we want to make sure that there's no other way that we can see an exposure between our exposure and our outcome except through this variable that we want to estimate. And you'll see that because C is associated with our exposure and our outcome, there is a path from the exposure and disease. There is some association here. And in DAG terminology, they often call this a backdoor path. And so we want to block any backdoor paths from our exposure to disease that could influence what we want to measure here. So we want to get rid of that effect, so we're going to adjust for it. And in DAGs, when we're adjusting for a variable, we put a box around it to say that we're adjusting for it. And when we adjust for it, then we're removing that association. There's no longer a way to get from E back to D, so that when we do our regression and we're estimating this effect, that's the only effect that we're estimating. And so let's put some words to these letters that we put on the DAG. And this is kind of a silly example. But what is the effect of cavities on happiness? Well, you might think that if you have a lot of cavities, you might not be that happy. So if we just look at this association crudely, we might not know what's going on here. But what about chocolate? We know that chocolate consumption is likely associated with cavities and also with happiness, especially. I think this is true. I think there is a causal relationship between chocolate and happiness. So if we're not taking into account chocolate consumption, we might think that cavities are positively associated with happiness, which doesn't quite make sense. So we want to adjust for chocolate consumption. So we're removing any pathway from cavities to happiness that is not the one that we're interested in. When we adjust for this, we're blocking that backdoor path, and we're able to estimate the true effect of cavities on happiness. So not always are all the variables directly associated like in the previous graph. Sometimes our confounder and our exposure are only related through some unmeasured variable. And that's the other common terminology that you'll hear in DAGs is these unmeasured factors. And we're not able in studies to measure everything that we would want to measure. So by making our assumptions explicit about what we have measured and what we don't have measured, we can make sure that we're blocking all of the backdoor paths. We can estimate the associations of interest to answer the public health questions that we're interested in. So here, again, we want to estimate that arrow. So we're going to remove it just so we can see if there's any other way, any other backdoor path through which we can get from E to D. And because U is associated with both C and E, they are going to be associated. And through that, we have this backdoor path from exposure to disease. So if we look at the effect of exposure on disease, we'll see some of this arrow, but we'll also be seeing some of this effect. So we want to get rid of any of the other backdoor paths. So we're going to adjust for the confounder and remove that association so that we can estimate the effect of E on D. And here, this is just highlighting that in our regression model, we would be adjusting for C. So let's put some words to this example. So here we're interested in the effect of alcohol on heart disease risk. We know that smoking behaviors are also associated with an increased risk of heart disease. And usually we see some relationship between smoking and alcohol behaviors. But they're probably not directly causally associated with one another, but they're probably more likely to be related through some healthy behaviors or unhealthy behaviors. So again, we're removing that arrow so we can see what other ways can we get from alcohol to heart disease that could be biasing our effect. So because of these unmeasured behavioral factors, smoking and alcohol are related here, causing there to be an association between alcohol and heart disease that we want to get rid of. We want to block that backdoor path. So we're going to adjust for smoking here to remove that arrow so that we can estimate the effect of alcohol on heart disease. So here in this model we're going to include both alcohol, because that's the effect we want to estimate, and smoking so that we can remove that other association. Are there any questions on confounding? DAGs? Yeah.
Quickly, so this is the conventional, so far, this is the conventional approach.
Conventional DAG approach?
Well, what you just did, this is this conventional way of adjusting, correct?
Yes. And even in DAGs or the conventional approach, any adjustment is either done through regression adjustment or stratification. So you can do the adjustment in any way. And the confounding matches much of the criteria that we talk about, the standard definition. It's a variable that's associated with the exposure and with the outcome. You want to make sure it's not on the causal pathway. So that definition is consistent with the DAG definition of confounding. So far it should be pretty similar to what we're used to. The next example that we'll talk about is collider stratification bias. And this is another term that often comes up in the DAG literature. And here, C is what is termed a collider. Anytime when you're working a path from the exposure to the disease and you come to a variable where two arrows are coming into that variable, those two arrows are colliding on C. And what happens is this is the case where when you adjust for C, you actually open up a backdoor path, and adjusting for C induces bias. So we'll walk through this a little bit. Here, because U is associated with C and D, there is some association between C and D. If you looked to see whether they were associated, you'd see some association, even though they're not directly causally related. Again, we're going to remove that arrow. When we adjust for C, it's like removing that arrow. We're removing the effects of the exposure on C. And what adjusting for C does here is we end up seeing an association between E and C, which opens up this backdoor path to the disease. So when you have a collider, the path is actually blocked before you start. But when you adjust for it, you end up opening up the backdoor path and creating bias. So this is a case where you don't want to be adjusting for C. And we're going to walk through this with the birth weight paradox example to show a little bit more about collider stratification bias. So just a brief recap. This is kind of the DAG definition of confounding, which is consistent, like I said, with the standard definition. It's associated with the exposure and the outcome, and it's not on the causal pathway. E does not cause C. C does not cause D. And like we said, sometimes they're not always directly causally related, but sometimes they're associated through some unmeasured common cause. And the DAG definition of selection bias, or the structural definition of selection bias, is this conditioning on a common effect. We have the two arrows coming into a variable. It collides there, and when we adjust for that variable, we're inducing bias. Okay, so we've gone through a very brief background on DAGs and kind of how they work. So let's see if we can use that to help us explain the birth weight paradox. So looking at the data, this is from the U.S. birth certificate data. When we look at the unadjusted effect of smoking on infant mortality, we see that smoking is associated with an increased risk of infant mortality. which is what we would expect to see. When we actually adjust for birth weight, we see that the effect goes down considerably. So using our change in estimate approach, here we would definitely want to put birth weight in the model. But here's where the paradox comes in. When we're looking at birth weight below 1,500 grams, we see that smoking is actually protective for infant mortality, where it's harmful for the infants that are born at normal birth weights. So here is an example of a DAG, one of the simplest DAGs we could draw to look at the effect of smoking on infant mortality. So here, smoking is affecting low birth weight, and low birth weight has an effect on mortality. So because smoking is associated with lower birth weights, and lower birth weights are associated with a higher risk of infant mortality, that's how we think that this is playing out. And so if we were to look at the effect of smoking on mortality, we'd see that smoking is harmful for mortality, which is what we would expect. But if this is what we think is going on when we actually adjust for low birth weight, there's no other way that smoking can affect mortality. And so when we adjust, we would expect the risk to be null, for there to be no effect. But really, when we adjust for low birth weight, we still see that there's some effect. So this particular DAG is not fully consistent with the data and what we're seeing. So what if smoking affects mortality through pathways not mediated by birth weight? So smoking, we saw earlier, does have an effect on the low birth weight distribution, but smoking has some direct effect on mortality. Here, whether we adjust for low birth weight or not, we're going to see the same effect if our world follows this DAG. But in fact, we saw very different estimates when we adjusted for low birth weight and when we didn't adjust. So again, this is a case where it's not consistent with the data that we saw. So what if we add an arrow here? What if the effect of smoking is only partially mediated by birth weight? So there is some of this where smoking affects low birth weight. Low birth weight is associated with mortality. And there's some direct effect of smoking on mortality. Here, when we adjust for low birth weight, we'll see some effect still of smoking on mortality. And our crude and our adjusted estimates, neither one of them will be equal to 1. And this is consistent with what we found. But really, you could argue it would be consistent with any data that the crude and the adjusted are not going to be the same and would be different from 1. So because you have arrows between all variables on your DAG, we have a complete DAG here, it's going to be consistent with any data that we have. So here, you might start thinking, well, there's got to be something else going on. Smoking through low birth weight and independently cannot be the only causes of infant mortality at play here. And we do know that there could be some unmeasured factor here. We don't have an estimate of birth defects or malnutrition in this population, but we know that birth defects and malnutrition affect the birth weight distribution as well as the risk of infant mortality. And so here we find ourselves in that situation where we have 2 arrows colliding on low birth weight. And because when we adjust for low birth weight, what happens is we end up seeing an association between smoking and mortality that could explain the paradox. So here is a case where when we adjust for a variable, if we think that there's more going on here, that there's a factor that affects birth weight and mortality, which it's very reasonable to think that there are other factors at play here. When we adjust for low birth weight, we end up biasing our association instead of it actually helping us out to adjust. And through simulations, we've seen that adjusting for low birth weight here, the bias is sufficient to actually flip the direction of the effect so that we would see that smoking is protective. The bias is not always that strong, but there are scenarios where the bias can actually flip the direction. And so in this case, this DAG is consistent with adjusting for birth weight causing the paradox. So let's walk through this a little bit more. So if we think that the only causes of low birth weight are smoking and birth defects, then each low birth weight infant, if their mom was not a smoker, then they had a birth defect. So those are the only possible causes. And we know that birth defects are associated with a much higher infant mortality rate than smoking. So what happens is when you look among the low birth weight infants, among those low birth weight infants, because of the higher risk of infant mortality for the birth defects, when you look at the effect of smoking on mortality among the low birth weight infants, it actually looks protective because there are only two causes, and the one cause is much more strongly associated. And so again, we're in the situation where adjusting for low birth weight is actually hurting us and causing the association to flip from what it should be. And the same rationale applies if there are other causes of low birth weight other than smoking and birth defects. So we can make this DAG more complicated to account for other factors. And as long as we see this structure with the two arrows coming into low birth weight, when we adjust for it, we actually end up inducing bias. And so here, whether or not there's a direct causal association between low birth weight and mortality, there's some argument of whether low birth weight is just a marker for other things going on that are actually affecting mortality. But whether or not we think there's a causal relationship here, when we adjust for low birth weight, we're introducing bias. So here, we've seen that the birth weight paradox can be explained as a statistical consequence of stratifying on a variable, here low birth weight, that is affected by the exposure and shares common causes with the outcome. And this is kind of the fancy DAG terminology for both of the arrows coming into low birth weight. They're affected by the exposure, smoking affects low birth weight, and it shares common causes with the outcome through the unmeasured variable, which we were calling birth defects, which is associated with both birth weight and mortality. So just to reiterate, using the typical methods for confounding adjustment, the data support adjusting for birth weight. It has a really strong effect, and so you would want to adjust for it. But the data and prior knowledge are consistent with DAGs that show that this change in estimate could be due to overadjustment or collider stratification bias. And so DAGs here really help provide a conceptual framework which helps summarize our qualitative beliefs about what we think is going on. And they clarify the appropriateness and the type of adjustment that we should be using. And they help us evaluate the relative disadvantages and advantages of the proposed analytical approaches to deal with the paradox. And again, let's just put the picture back up. It's when we're stratifying by a variable that is affected by the exposure, which shares a common cause with the outcome that causes this collider stratification bias. So what the DAGs can't do is actually tell you how much bias you're going to see. The approach only shows you whether or not you should be adjusting for it, but not how much bias could be induced. So that's where it gets kind of iffy. You know, what if you're in this case and you are adjusting for something that you shouldn't be? Is it going to be strong enough to flip the association and make a wrong conclusion? You have to use other methods and simulations to try and figure out what the potential magnitude of that bias would be. But the DAGs can help us know when we should and shouldn't be adjusting for these factors. So to summarize the birth weight paradox piece, the causal structures provide a clear-cut classification of confounding and selection bias. So when you start drawing your DAGs of your own research, you can pick out these different structures. Confounders are common causes. And you can also pick out colliders. If you see two arrows going into a variable, you know that adjusting for that actually opens the path. And so you have to be careful about making sure that all the paths are blocked. Really, we need to know the causal structure in order to be able to label a variable as a confounder. Just seeing how strongly it's associated with the exposure and outcome is not enough. The statistical criteria won't quite get you there. You need to put your assumptions on a DAG and look and see what the structure looks like to be able to know if a variable is in fact a confounder or a collider. And DAGs are a really useful way to summarize our beliefs about the causal structures that are compatible with our subject matter knowledge. So this is where we get to be epidemiologists versus just biostatisticians. We get to use what we know about biology and the situation of what's going on and really decide which factors we need to be thinking about. So we're moving kind of fast, going through the paradox and a background of DAGs and how DAGs could help us explain the paradox. And there's one other case which we'll go through pretty briefly, marginal structural models. I think are also kind of a buzzword that we hear along with DAGs. So we'll introduce you to what a marginal structural model is, when it's needed, and it's only one simple extra step to actually run the marginal structural models. I think we hear about these fancy models and get worried about implementing them, but really it's only one extra step to run the weight models, which we'll talk about, and then you can appropriately adjust for confounding in this way. So like DAGs, the name marginal structural model has a very specific definition. Marginal comes from the fact that we're modeling the marginal distribution. Typical regression methods, we're estimating conditional effects. And we'll talk about what a counterfactual or potential outcome is. But they're titled structural models because we're modeling this probability of counterfactual outcomes. And this term comes from the social science literature. And it's a model because it's showing how we think the world works. So what is a potential outcome? In causal inference, we like to think of each individual having two potential outcomes. There could be more, but we'll focus on two because it's easier to think about two. One that would be observed if they were treated, and one that would be observed if they were not treated. So I want to know what the effect of smoking is on my probability of having lung cancer. We talk about wanting to have a time machine. So you'd want to follow me, look at my life. If I don't smoke, follow me till the end, see if I got lung cancer. The only way to know if smoking caused my lung cancer is then if you could rewind. I smoked throughout my life, and you see if I got cancer or not. Then you can compare the outcomes. If when I smoked I got lung cancer, when I didn't, I did not lung cancer. Pretty high probability that if everything else was the same, that smoking caused my lung cancer. But we know that that's not possible. We can't use a time machine and go back and follow everyone and see what would happen if they had an exposure in one life and didn't have the exposure in another life. We only observe one potential outcome. But in a causal inference, what we want to do is really estimate these causal effects. Even though they're defined on the individual level, we want to know what it is for each person in this room. What we're going to end up doing is estimating the average causal effect of treatment. So we look at the population and we see how many people smoked, how many people got lung cancer, how many didn't smoke, how many got lung cancer, and we estimate the average causal effect in a population. And based on several assumptions, then we like to make the conclusion that smoking does or does not cause lung cancer. Which, as epidemiologists, I feel like you always get worried about making causal statements. We're always very careful to say that something is only associated with something else. We don't know. Because we can't do a randomized trial for every exposure that we want to look at. And so in causal inference, what we're trying to do is set up the population so we balance everything so it looks like a randomized trial. So all the factors are equivalent except for the one that you're interested in, and you estimate the causal effect in that way. And that's why the assumptions are so important here. But we're making them all the time anyway. We're just not always being explicit about them. So this gives us a chance to be more straightforward about the assumptions. And so the motivation for using marginal structural models in causal inference comes from the fact that oftentimes we find that we need to adjust for time-varying confounding affected by prior exposure. And we'll talk about what that means. If we're in a non-randomized treatment setting, at a single time point, we can put it in the regression model if it's a confounder based on what we've talked about before, and we'll be okay. But if we're looking at an exposure over multiple time points, the typical adjustment won't work. So here is a DAG where we have an exposure at time 0 and an exposure at time 1. We also have a confounder that's measured at 2 different time points, at time 0 and time 1. And we want to know the effect of the exposure at all time points on our outcome. But what happens if we adjust for C here? We're adjusting for an effect of the exposure. And we know that we don't want to adjust for a variable that's on the causal pathway. So we shouldn't be adjusting for C. But if we don't adjust for C, C1 is a common cause of our exposure and our outcome. So here we're in a situation where there's confounding by C1 that we need to take care of, but when we adjust for it, we're adjusting for something that we shouldn't be adjusting for. So what can you do in this setting? This is where you need the marginal structural models to estimate the effect. And how I kind of got into this causal inference realm was being interested in the effect of estrogen on lipoprotein levels. And I'll walk you through a DAG that we built that made it clear that we needed marginal structural models to estimate the effect. And the interesting thing about the effect of estrogen on lipids is they noted in the Women's Health Initiative trial that the women on hormone therapy had lower cholesterol levels than the women who didn't. And so we wanted to see whether there was some association between estrogen and lipids among premenopausal women as well. So here we are interested in the effect of estrogen on lipids, and we know that there are other reproductive hormones, LH, FSH, and progesterone, that are associated with estrogen and also associated with lipid levels. But we looked at these across 2 menstrual cycles. So we know that estrogen levels in one cycle, pick the right arrow, are associated with estrogen levels in the next cycle. And your lipid or cholesterol levels in one cycle are related to those in the next cycle, and the hormone levels as well. But we know that there are other factors that affect these relationships. Diet and physical activity affect your hormone levels and your cholesterol levels. And when you draw a DAG, start with what you know. And don't freak out when it starts to get complicated. I think that's the number one rule. So we know that there are other factors. And then we're going to look for some of those structures, the confounding and selection bias that we were talking about earlier. And here we see that the other hormones represent a time-varying confounder. They're varying from one cycle to the next, and they're affected by prior exposure. So estrogen levels in the first cycle are associated with hormone levels in the next cycle, but these hormones are a confounder. They're a common cause of estrogen levels and lipids. So here we're in this case where we want to adjust for these hormones to take care of this confounding, but because estrogen affects these levels, we shouldn't be adjusting for them. So we need marginal structural models. So here the standard approaches are inadequate. We can't just put these other hormones in the model. If we adjust, we could be over-adjusting, but if we don't adjust, there's some confounding that we're not taking care of. And so the marginal structural models allow for improved adjustment. And the way they work is you estimate inverse probability weights. you calculate the probability of an individual receiving the treatment they actually received conditional on their observed covariates. So you want to know what's the probability that I had the hormone levels that I actually, the estrogen levels that I actually did based on my age, my BMI, and my other hormone levels. And so we're going to get this probability for each person. We're going to weight each subject by the inverse of that probability. Once we have the weights, then we run a weighted regression model to estimate the causal effects and the parameters of the marginal structural model. And so the weights, like I mentioned before, what they're doing is they're balancing all of the confounders across those who were treated and who were not treated so that it looks like a randomized trial where everything is the same. There's the same numbers on both sides. The only thing that's different is the treatment. So then when we go in, we can look and see what the effect of that treatment is. And so the weights take the data that we have. If you only have one person in the low BMI category and at a certain age, they'll give that person more weight, give them more copies in the population to make them equal to the treatment population. So this is the formula for the weights. But what's important to notice here is we're going to be estimating the probability of exposure. And you only need to estimate one additional regression model to get the weights. But here, you're going to regress your exposure and include the time-varying factors, so here are the hormones, and the non-time-varying factors, the age, the BMI, the physical activity. We're going to adjust for all the confounding through the weights. And you only need to do one additional linear regression if your exposure is continuous, or one additional logistic regression if your exposure is dichotomous. And so we're running these models anyway, and these are things that we know how to do, how to run these linear and logistic regression models. So we calculate one for the weights. When we have the weight models, we have the weights for each person, then we run a weighted model. Usually the steps are we just run a regression, just one regression. But here we estimate the weights and then run a weighted regression, and we can appropriately adjust for the time-varying confounding. So the marginal structural models provide a valuable tool for the situation that we often find ourselves in where we have a time-varying confounder affected by prior exposure. And you can really easily implement them in standard software. And we need to make sure that we're thinking about the assumptions that we're making and clearly stating them and noting them in the limitations. So why do we want to use DAGs? Well, they help us determine the appropriate adjustment set. Is a variable a confounder? Do we want to adjust for it? Or is it a collider and we shouldn't be adjusting for it? It also helps identify time-dependent confounding. If we're in a situation where adjusting for something could cause bias, but not adjusting for it could also induce some bias. And so here we need marginal structural models, which are an easy extension of the models that we're already running, so we can appropriately adjust for that confounding. And they make our assumptions explicit. So that's a brief intro to DAGs this morning. This represents the work of a lot of people. I want to thank my collaborators and thank you for your attention. Happy to take any questions.